In this module, we'll look at the clinical correlations for upper and lower limb somatosensory evoked potentials. Somatosensory evoked potentials have specific clinical utility and can be very helpful because there's a close relation between the evoked potential waveform and the underlying anatomic structure. This relationship allows the clinician to localize conduction deficits in the brainstem with a specificity of a few centimeters or so. Because of their anatomical distribution, SEPs are a sensitive tool for assessing spinal cord function, and in particular the brainstem posterior column and medial lemniscal tract functions. Also, SEPs are fairly resistant to anything other than structural pathology, and we will discuss this later in the slide that discusses factors that affect SEPs. Some of the clinical applications of SEPs include, in neurological assessments, SEPs can be used to identify demyelinating, dysmyelinating, and degenerative conditions. The SEP can be more sensitive than MRI if the lesion is small. Because of the sensitivity of the SEP, it can be used to monitor disease progression or the effects or efficacy of a therapeutic intervention. It can also localize lesion sites and can therefore be useful to differentiate peripheral versus central disease. In the operating room, the SEP can be used for intraoperative monitoring, especially for procedures involving the spinal cord and brain stem. At Sick Kids, we use the SEPs as part of our pre-surgical mapping protocol for epilepsy surgeries. Specific abnormalities of the SEP have been associated with specific conditions, so it can also be used as a tool for differential diagnosis. Finally, there is ongoing research investigating the utility of SEPs as a prognostic tool in a number of conditions, such as coma, acquired brain injuries, traumatic brain injuries, anoxic brain injuries, and in various populations, including neonates, children, and adults. While the SEP is quite robust, there are some factors that can affect it, especially in children, and these must be considered when interpreting the SEP study. Some physical factors that need to be taken into account include the patient's age and size. If the patient is very young, the somatosensory system is not yet mature, and therefore the responses are later than what would be seen in someone who's slightly older. However, as the somatosensory system matures and conduction speeds up, the patient's size begins to play a role. That is the patient's height or limb length. Longer arms and legs require longer conduction times, and therefore this will increase the latency of peripheral responses. All this to say that it's important to use upper limits of normal values that are appropriate for both the patient's age and their limb length. Note that if a patient has long limbs, then the upper limit values for the appropriate limb length may be used. But when looking at central conduction, the upper limits for the interpeak latencies should be the values for the appropriate age. Therefore, two different tables may be used when looking at upper limits of normal. If a patient is cold or undergoing hypothermic intervention, then this will slow the conduction of the SEP and will increase latencies. It's important to note if this is the case. If the patient has a peripheral nerve problem, this will affect SEP latencies and may even render the SEP absent or abnormal. In the operating room, if the patient has been given a muscle relaxant, then this will affect the technologist's ability to obtain a motor threshold. If the patient has been sedated, the cortical components may be of lower amplitude and longer latency. If the technologist notes that the latency of the cortical components are delayed while the peripheral components look normal, and if it is safe to do so, it is helpful to change the state of the patient a little, that is, to rouse them a little and record any changes in the latencies of the cortical components. This must be well annotated so that the neurophysiologist can interpret the latency changes appropriately. Other than this, the SEP is quite resistant and sedation will not affect the peripheral responses. In babies under 4 years of age, deep sleep may affect the cortical components. However, natural sleep, regardless of sleep stage, should not affect individuals over the age of approximately 4 months. Finally, there's increasing interest in using SEPs for research studies. If this is the case, be aware of the above factors, but also be aware of the evidence and the specific conditions where SEPs have demonstrated utility. And also, consider doing prognostic SEPs serially to ensure that the results are robust and reproducible. This is a picture of an SEP in a neonate recorded while awake in the top tracing and in deep sleep in the bottom tracing. In infants under 4 months of age, the N20-P22 cortical components can be prolonged when they are asleep and will become of normal latency when they awaken. In children over 4 months of age, the cortical components should not be substantively affected by natural sleep. An SEP is considered abnormal when at least one of the following criterion are met: the absence of a waveform or component, an increase in the absolute latency of a peripheral component, or an increase in the interpeak latency of a central component. Amplitude in and of itself is not usually a criterion for abnormality. However, an amplitude asymmetry of greater than 50% is, whereby the lower amplitude side is usually the abnormal side. We will now look at how to interpret these abnormalities. If the peripheral response, that is the N9 for the median nerve stimulation, and the popliteal fossa response for the posterior tibial nerve stimulation is absent, the first thing to consider is whether there is a technical problem. It should be confirmed that the stimulation is working and that there is a motor activation. If the stimulus is working but there is no motor response and there is no peripheral response, then the patient may have a peripheral problem. If the peripheral waveform is observed but delayed, check the limb length to make sure the correct upper limits of normal values are being used for the patient's limb length. Check also that the patient is not cold and has not undergone hypothermic therapy. If these have been ruled out, then the patient may have a peripheral dysfunction. If the cervical or lumbar responses are absent and the peripheral responses are absent and all technical factors have been ruled out, then the patient probably has a peripheral dysfunction. If the peripheral responses are preserved and the cervical or lumbar responses are absent, then there's a dysfunction between the peripheral generator and the entry into the spinal column. For the median nerve upper limb SEP, this would suggest a dysfunction at the brachial plexus, and for the posterior tibial nerve SEP, this would suggest a dysfunction at the cauda equina. If there is an abnormal latency observed for the N12-N13 on the upper limb, or the N18-P21 on the lower limb, and the peripheral latencies are within normal limits, this would suggest a nerve root dysfunction or radiculopathy. However, if the peripheral latencies are also abnormal, then one cannot dissociate the source of the increased latency, and it could either be from the periphery or it may or may not include the nerve root. An absent cortical response must be interpreted with caution. For the upper limb median nerve response, if the N20-P22 is entirely absent, but the peripheral response is present and clear, then there is a central nervous system dysfunction. However, if the peripheral response is not clear, then the absent cortical response cannot be interpreted. For the lower limbs, if the N30-P35 complex is entirely absent and the popliteal response is seen, then there is a central nervous system dysfunction. However, if the popliteal response is not clear, then the absent cortical response cannot be interpreted or must be interpreted with caution. Please note that there are a lot of individual variations of the cortical response and that the obligatory responses are the N30 and P35. In some patients, especially in younger patients, the subsequent waveforms, the N45, P55, may not be well seen, it may not be well formed, or it may be of lower amplitude. Also, as already mentioned, low amplitudes are not usually clinically interpreted unless there is an amplitude asymmetry between the two arms or between the two legs, with the asymmetry being greater than 50%. If there's a delay in the absolute latencies of the cortical responses without a prolongation of the interpeak latencies, this is very difficult to interpret. What is most useful in looking at latencies is looking at the interpeak latencies. Looking at the latency between the cervical to cortical response for the median nerve stimulation, or the lumbar to cortical response for the posterior tibial nerve stimulation, is useful for understanding central conduction function. While absolute latencies can be affected by a number of factors, interpeak latency is the measure of central conduction. Therefore, if the N13, N20 interpeak latency for the median nerve study, or the P21, P35 interpeak latency for the posterior tibial nerve study is prolonged, then this suggests a central conduction dysfunction. Note that regardless of limb length, interpeak latencies are compared to the upper limits of norm for the patient's own age. So even if they're tall, even if the limbs are long, the upper limits of normal values should be used for the patient's own age. If the interpeak latencies between the subcortical to cortical peaks, that is, the N20 to P22 on the upper limb testing, or the P35 to N45 on the lower limb testing, if these latencies are prolonged, this would suggest a cortical dysfunction or an intracortical delay.